So welcome everybody. We are at a webinar organized by the IMI-AMR Accelerator. I'm Frédéric de Rose, a part of COMBINE, and I'm very happy that we have a webinar jointly with ERA4TB. This webinar hopefully will generate a lot of interest from you. And just some technicalities, if you can mute yourself during the session, we will have plenty of time for Q&A. Please also don't use your camera for the bandwidth so that we can have a good connection. Indeed, there will be recordings afterwards shared with everybody. The floor is yours, Catherine. So welcome, Catherine Cresswell, and then will be moderating this session today.
Yeah, thanks so much, Frederick. Yeah, welcome everyone to this webinar on the cost of treating tuberculosis. As Frederick's mentioned, the webinar today is hosted by the ERA4TB project and the COMBINE projects. So ERA4TB is a European-funded research project. There's over 30 partners, and we work on the early phases of tuberculosis drug development. And as Fred mentioned, we're both part of the IMI Accelerator. This is an umbrella project that encompasses 9 projects focused on antimicrobial resistance and tuberculosis research. And the COMBINE project provides support across those. So a big thank you to Frederick and our colleague Tolga for setting up the webinar today. So just briefly, just wanted to acknowledge our funder, which is the Innovative Medicines Initiative, and just to say that any views expressed today are not those of our funding partners. Just wanted to start by saying what we're hoping to cover today. So thank you so much for joining. The aim of today's session is really to provide an introduction to the topic of health economics and tuberculosis. I know some of you will be really familiar with some of the health economic concepts and some of you won't. So hopefully we'll give you a little bit of an introduction. We want to examine the costs associated with treating tuberculosis and how these are measured. And we also want to explore how health economics supports setting priorities for drug development. And I'm really pleased to be joined by 2 absolutely fantastic speakers today. So we have Dr. Sedona Sweeney, who's an associate professor in health economics from the London School of Hygiene and Tropical Medicine. And Sedona will be talking to us about estimating costs of TB services and programs. And we're also joined by Dr. Laura Rossu, who's formerly from the Liverpool School of Tropical Medicine, and she'll be presenting on the economic cost and cost effectiveness of treatment strategies and care models to reduce the burden of multi-drug resistant tuberculosis. And as Frederick said, we'll have time for questions and answers, so please feel free to put your questions into the chat as we go along, and we'll try and address as many of those as we can at the end. So before I hand over to our speakers, just very briefly, I just wanted to touch on what health economics is. As I mentioned, I know not everyone will be completely familiar. And I know sometimes people think health economics is all about trying to do things for the least money possible, trying to do things in the cheapest way. But actually, health economics is the study of allocating scarce resources to produce the most health. So looking at how we can take limited resources and get the most help from them. And to do this, we also need to study how health and health services are distributed among individuals and groups in society. And some of the things that health economics can do, as I said, it's promoting efficient use of health resources, but they can also be used to control aggregate healthcare costs and provide a set of tools and management for decision making in selecting the priorities. And in terms of TB, why is this important? So I had a look at the World Health Organization Global Tuberculosis Report from 2023, and I just pulled out a few key sentences that I thought kind of really related to this topic. So the report says that progress in reducing the burden of tuberculosis requires adequate funding, sustained funding over many years, and that it's estimated that for TB prevention, diagnostic and treatment services in lower and middle income countries in 2022, there was an estimated cost of $15 billion US, so a huge amount of cost there. And actually these cost estimates have increased to between 15 to 32 billion over the coming years. and that at the moment, funding available for TB prevention, diagnostic and treatment services falls far short of the globally estimated needs. There's a real need to consider resource allocation here. So finally, I'm just going to finish by just highlighting a paper that ERA4TB published last year. Some of my colleagues did a systematic review of economic evaluations of pharmacological treatments for active tuberculosis. So you can scan the QR code here, or you can also access this paper through the ERA4TB website. So if you're interested in the topic, please do have a read. So I'll stop sharing there, and I will now hand over to Sedona to start her presentation.
So thanks so much for having me. Just to introduce myself again, I'm Sedona Sweeney. I'm a health economist at the London School of Hygiene and Tropical Medicine. And I'll be walking you through sort of some of the cost and cost effectiveness evaluations that we've done recently on TB, and specifically on the BPAL and BPALM regimens. So just for those who are new to economics and to the idea of cost effectiveness analysis, just a quick definition of what economic evaluation is. So economic evaluation is the comparative analysis of alternative courses of action in terms of both their costs and their consequences. So it's really just a framework that we use to help us make difficult decisions in producing and purchasing healthcare. And it's based on this idea that Catherine talked about of scarcity. So the potential for technological innovation in health is theoretically unlimited, but the resources that we have to produce and purchase those innovations are by definition limited. And so we need to have some sort of decision-making framework to help us sort of establish what is a good investment and what is potentially a waste of those limited resources. So economic evaluation really just helps us answer this question of is it worth it, right? So some of you may have seen this type of graph before. This is called a cost effectiveness plane, and it compares the new treatment that you're trying to judge against an old treatment in terms of cost and effectiveness. So for example, if a treatment falls in the top right of the quadrant where it's more costly and less effective than the old treatment, then the answer is pretty clear that it's not worth it. It's not a good investment. And so you should keep on using the old treatment. If it falls in the southeast quadrant where it's more effective and less costly than the old treatment, then again, it's a pretty clear decision that it's worth it. It's a good investment. It'll probably save you money in the long run and probably improve health at a population level. Decisions are more difficult in the first and third quadrants of the graph, so where it's more costly but more effective, or less costly but less effective. And for this, we have, we typically use rough guidelines called willingness to pay thresholds. So, for example, NICE in the UK uses a rough guideline of, if your new technology is less than £20,000 per additional quality gained, then the decision to recommend the use of the technology is usually pretty straightforward. If it's more than that, then you need to identify an increasingly stronger case for why your new drug or new technology needs to be used within the NHS. So how is a cost effectiveness study done? Well, we're really, we just compare two interventions in terms of their costs and their health effects. So we usually estimate all of the delivery costs of each of the intervention, all of the health effects that produces, and then all of the costs attached to each health effect or each potential event. And this is usually done over the course of a lifetime for a patient. And for that, we often use decision analytic modeling to help us identify, what's happening after, for example, after a trial finishes. So I'll give you an example of a recent study that I did that was a cost effectiveness analysis that will sort of highlight some of the things that we evaluated. So TB Practical was an open label, non-inferiority randomized control trial evaluating 3 regimens based on the backbone of BPAL, bedaquiline, pretomanid, and linezolid, We evaluated BPAL plus clofazimine, BPAL plus moxifloxacin, called BPALM, and BPAL alone. And the trial was terminated early for benefit in 2022. And we found a substantial reduction in the number of participants with an unfavorable outcome in the trial. So to do the cost effectiveness, first we looked at the drug costs. So here you can see the mean total cost just on drugs per patient episode of care. So from the point that they started treatment until the point that they ended treatment. You can see that the shorter standard of care regimen on average was a little bit cheaper than the BPAL and BPALM regimens. The longer standard of care regimen was much higher, which is perhaps not surprising. And it was driven by a few very high cost drugs. So for example, delaminid in the bright blue was only taken by 21% of patients, but made up the majority of the total cost. And then taururzidone was only, in the khaki at the top, was only taken by 12% of patients, but again, accounted for a sizable chunk of total patient drug costs. We then also included all of the costs that were associated with delivering care for the patients in the trial. Again, from the point that they started care, usually until they died, or over the course of 20 years. So this included things like inpatient bed days, lab tests, outpatient visits, any home visits or phone calls that were required to encourage adherence, and then any patient-incurred costs. So both direct out-of-pocket payments that patients made, not only to the trial facilities, but to any type of healthcare provider, including pharmacies, GPs, traditional health healers, that kind of thing. And then also any indirect costs. So for example, income lost as a result of their TB and as a result of being ill. We combined all of this economic data and the output epidemiological data from the trial into a Markov model to project this over the course of their lifetime. So we tracked patient events and health status for 20 years, and including loss to follow-up and return from loss to follow-up, and movement to a longer standard of care regimen in the event of treatment failure or in the event of relapse. And we found that all three of the BPAL-based regimens were cost-saving and improved health outcomes as compared with the standard of care. So it put the new treatment, BPAL, firmly in the sort of the bottom right quadrant, where it is more effective and less costly, and therefore a clear decision that it should replace the standard of care. I also just wanted to highlight a few other studies that I've been lucky enough to be involved in the last few years about looking at novel regimens. So first, Tess Rickman and colleagues looked at what characteristics of a new regimen might be important in terms of cost effectiveness. So they found, for example, that shortening regimens from 6 months to 2 months increase the medium-term cost neutral prices by approximately $90 to $240. So this means that you would theoretically be able to charge $90 to $240 more for a regimen and still, fall within this southeast quadrant, or at least on the line where it's no more costly, but still potentially more effective if you could reduce the treatment duration to 2 months. And this is for RIF-susceptible regimens. They also found that increasing adherence for patients was important, and that improved safety was particularly important for RIF-resistant TB. Next, James Linden and colleagues looked at introduction of BPALM in Moldova on the impact and cost effectiveness with and without upfront drug susceptibility testing. And they found, sort of surprisingly, that the frequency of second-line drug susceptibility testing didn't lead to large differences in health or in cost outcomes. They found that BPALM could shorten the average duration of TB that was resistant to quite a large handful of drugs, but that it might increase average duration of TB resistant to delaminid and pretomanid. And then finally, I wasn't involved in this study, but I think it's interesting and very important. So Dabney Evans and colleagues in South Africa looked at the patient and provider incurred costs of BPAL as it was rolled out in South Africa. And they found that the cost incurred by patients and their households decreased by 75% as compared with the current standard of care for the patients who enrolled on BPALM. They also found that BPALM patients had less perceived financial impact on the household, less borrowing, and less food insecurity. So these are some recent studies that have looked at shorter and less toxic regimens. I think there are a few remaining questions that could be evaluated. So the first is whether these sort of new regimens could improve the pace of household economic recovery following the shock of TB. So we know that TB can potentially impoverish patients and their households. And I think what we don't yet know is whether putting people on improved regimens can help people to recover from that more quickly. Similarly, I think we don't know really whether shorter or less toxic regimens have any role to play in the impact of long-lasting TB health effects. So we're seeing more and more that post-TB is an issue, and that it can often be lifelong disability. I think it would be interesting to evaluate whether shorter and less toxic regimens can reduce that lifelong impact. And then finally, I think we need some real-world studies to look at whether countries can effectively repurpose the resources that are saved as a result of shortening treatment duration. So in TB Practical, we saw a very clear savings in theory from reduced treatment duration. People were going to the health facilities less, they were having less visits, fewer inpatient bed days, and therefore their costs were lower. But it would be useful to see, what those health facilities are then using that time on. Are they able to pivot and provide other services in that time that they would be potentially providing TB care? That's all I have for today. Thank you so much again. Looking forward to the discussion.
Over to you, Laura.
Fine, thank you. And thank you, Sedona, for introducing the economic evaluation concepts, because I'm going to use some of them in the presentation. Hello, everyone. My name is Laura. I worked on the STREAM trials for about 7 years. And today I'm going to present some of the results of the STREAM trials and the care models we tested in some of the models we constructed based on the STREAM data we had. So just a quick introduction. The STREAM trial was conducted in 2 phases. It was a phase 3 non-inferiority RCT that in phase 1 tested the 9-month Bangladeshi regimen versus the usual 24-month regimen, both containing injectables. And the second phase tested 2 other regimens. So it tested a 9-month all-oral regimen and a 6-month regimen containing beraquilin and also an injectable for the duration of 2 months. And this is just a graphical representation of the treatment regimens that were tested in the first phase of the trial. And from an efficacy point of view, it showed that the 9 to 11-month Bangladeshi regimen was non-inferior to the 20-24-month regimen. We've also collected data in economic data in Ethiopia and South Africa, and we've done that because even if we were comparing regimens of different durations, we just weren't sure that the new regimen would result in more unfavorable outcomes that would require retreatment or more serious adverse events that would, of course, require treatment again. And these 2 types of unfavorable outcomes and SAEs are quite costly to treat. But luckily, that wasn't the case. So as you can see from this picture, from this graph, both in Ethiopia and South Africa, the shorter regimen, the 9-month, injectable containing regimen was less costly when it comes to the health system costs. If you can see, the difference comes from the continuation phase mainly. The cost for the intensive phase were pretty much the same for both countries. And we've also collected patient cost data, direct and indirect costs. And here on the left-hand side of the graph, you'll see the proportion of patients working 8 hours or longer a day. And you'll notice that patients on the shorter regimen were working longer hours compared to those on the long regimen, starting from week 0, so the baseline, up until about week 108. So that's when patients from the longer regimen ended their treatment and they started working a bit more, but the difference was not statistically significant. We've also collected data on direct costs, and the costlier part of the direct costs were the supplementary food purchases. And these were purchases that patients were making to supplement their treatment. It wasn't a requirement of the trial. It was based just on their decision. And they were buying things like eggs, meat, vitamins, more than they were usually buying when they were not sick. And again, from this graph, you'll see that those patients on the short regimen were spending less on these supplementary food purchases compared to those on the long. And the difference in terms of costing maintained even after patients on the long regimen finished their treatment, which is where the vertical black lines are, the second vertical black line. I won't talk too much about it now. If you want to read more about it, it's in this paper published in the Bulletin of the World Health Organization. But I want to talk about the impact it had. So we presented these results together with the clinical results to the WHO guideline group in 2018. And the results contributed to the formulation of the 2 WHO updates on management of MDR-TB and one consolidated guideline endorsing shorter regimens, and the economic benefits of them were specifically mentioned. And also this methodology we used in Stream 1 was also used in the short research package developed together with WHO. These were the guidelines I mentioned. And here it specifically mentioned that the shorter length regimen is a main advantage to the patient because it has an earlier return of the patient to work and social activity, and also the reduced cost of the shorter regimen to patients and the health services is expected to favor equity. And now I will start talking about the second phase of the STREAM trial. And again, this is the graphical representation of the regimens that were tested. Again, the regimen B was the Bangladeshi regimen, 9-month injectable containing, C, 9-month all oral, D, a 6-month injectable containing for 2 months. And in terms of the efficacy results, the regimens C and D had superior efficacy compared to regimen B. So they weren't just non-inferior, they're actually superior. In terms of the health economic data, we collected these along the STREAM stage 2 trial. We collected patient cost data and health system cost data up to week 76 in 4 countries, India, Ethiopia, Moldova, and Uganda. And we collected 2 types of costs. So we collected patient costs, direct and indirect, and also health system costs. So we not just looked at the medication costs, we also looked at inpatient stay, lab costs, social support, serious adverse events. And in our analysis, we considered 2 types of outcomes. First, the QALYs that were patient-reported and collected throughout the trial, and we used that in the cost-utility analysis, and the trial's efficacy outcome for the cost-effectiveness analysis. We adopted 2 perspectives, the health system, where we only looked at the efficacy outcomes and the QALYs, and the health system costs, and the societal, where we also looked at the health system plus the patient costs. And because we had 3 regimens we looked at, we had 2 comparisons. So it was oral versus the control and 6-month versus control. From this, you'll see the mean health system costs in all 4 countries, Ethiopia, India, Moldova, and Uganda. You will see that for Moldova and Uganda, we don't have cost for the 6-month regimen. And the reason is that we have below 10 patients enrolled in those two countries. So we thought the analysis won't be relevant. You'll also notice that the oral regimen had the high health system cost, higher health system cost compared to all others. So it was more expensive than control, more expensive than the 6-month in all countries. Of course, the absolute differences between the total costs were different across countries. And the differences were coming from either inpatient stay duration. I just wanted to mention that the trial did not impose a required inpatient stay. So it was at the decision of the treating clinician. And also you will see that some of the differences are coming from the regimen medication, which includes drug costs as well, but also the costs that we had to pay for retreating the patient who had an unfavorable outcome. As I said, we also collected patient costs for the oral versus control, and the mean direct costs were lower in the oral arm than control in Ethiopia, India, and Moldova, and higher in Uganda. So there was no clear trend here. And as for stream 1, the supplementary food expenditure was the main cost driver for patient direct costs. And also in terms of income loss, this was higher in the oral regimen in Ethiopia and India, and lower in Moldova and Uganda. And of course, the same trend, because the income loss was way more higher than the direct cost. The same trend remains in the total indirect costs. And you will see that two countries had cost savings, 2 countries had these savings. So there was no clear trend in terms of which regimen saves more patient costs. So we looked at the health system, we looked at the patient costs. So now we're going to look at the cost utility and cost effectiveness analysis. So for the cost utility analysis, this is where we use the quality adjusted life years as an outcome. As I said, we collected quality adjusted life years from the patients from week 0, from baseline up to week 76, just to understand how they were feeling. So these are all patient reported. And you will see that in Ethiopia, India, and Uganda, the oral regimen was considered more costly and had lower quality, so poorer outcomes, which means that we won't say that this treatment is cost effective. When it comes to Moldova, this was the overall oral regimen was less costly when we included the indirect cost. If you remember from the previous slide, the Moldova had really high indirect costs, and that balanced out with the difference in the health system costs. So overall, treating patients in Moldova was considered less cost. Treating patients with the oral was considered less costly than treating with a 9-month injectable containing, and also resulted in more qualities, which means that the oral regimen was considered less costly and had better outcomes. So it would be considered cost effective. When it comes to the cost effectiveness analysis, so this is when the trial efficacy outcome was used, and we used the pool estimates just to gain more power. Again, this is from a societal perspective. So in Ethiopia, India, and Uganda, the oral regimen was more costly, but also more effective. And we'll talk about that in a second. I just want to mention Moldova. Again, the oral regimen was considered less costly and more effective, so was dominating the 9-month injectable containing. So this would be considered cost effective. So in terms of Ethiopia, India, and Uganda, what we would usually do, and as Sedona also mentioned, we would compare the ICERs with a willingness to pay threshold. However, we didn't quite have willingness to pay thresholds that were calculated in country and that we were very confident in using. So the threshold could have been here or here or here or anywhere else on the graph. So what we've done instead was we've constructed some cost effectiveness acceptability curves of the oral versus control regimen, and we arbitrarily set a threshold of 80% probability of being cost effective. So how we calculated the willingness to pay threshold was when the line reaches the 80% probability of being touches the 80% probability of being cost effective, that's how much the willingness to pay threshold should be. So as you can see here, Moldova has over 80% probability of being cost effective at any willingness to pay threshold. If you remember, Moldova was considered cost effective. And for India, the willingness to pay threshold for the oral regimen to have 80% probability of being cost effective should have been 3,150. For Uganda, 4,350, and for Ethiopia was really high at 15,900. Now we're looking at the 6-month versus control, and even though the 6-month contains an injectable, it was quite well received by the clinicians from the trial and also by the patients. Again, just as a reminder, we had a low number of patients enrolled in the 6-month arm in Moldova and Uganda, so we won't present those data. The mean direct cost was lower in the 6-month arm in Ethiopia and India, and the difference was statistically significant in India, and same for the income loss. So the 6-month was overall lower in both countries. Again, when it comes to the cost effectiveness analysis, the 6-month regimen is considered cost effective in both Ethiopia and India. But when it comes to the cost utility analysis, when we use the QALYs as an outcome, so India is cost effective. In Ethiopia, what was happening was that the regimen, the 6-month regimen, was less effective. However, it generated a little bit, just tiny bit less QALYs, which basically means that the treatment regimen would be considered cost effective in Ethiopia if the willingness to pay threshold would be lower than 14,000. So when your threshold is really high, it basically means that you're willing to pay more to get that teeny tiny effect in terms of QALYs. Just as a just some conclusions for the STREAM trials. So the results were robust. Most of the sensitivity analysis we've conducted. The oral regimen, the 9-month, from a health system perspective, these data are not here, but they are in the paper, show that the regimen is likely not to be cost effective in any of the countries. And the 6-month regimen reduces participant cost and results in lower health system costs. I also wanted to mention that my colleagues have rerun an analysis of these with updated unit costs, and there will be a publication which is going to probably show that the cost effectiveness of the treatments have changed since this paper was published. Again, if you want to read more about it, this is the paper to look at. So in STREAM, we collected loads of patient cost data, and we were seeing that patients were spending a loads amount of money on attending assessment visits first, and second, on attending their daily DOTs. And we also know that the treatment completion rates for MDR-TB are low. They're about 50% globally, which highlights the fact that we shouldn't only be looking at treatment regimens or just improving the treatment regimens. We should also be looking at how treatments are being delivered. Because these are critical to improve adherence and outcomes, and can also accelerate progress towards the SDGs. And we looked very carefully onto the WHO guidelines, and we saw that in 2017, there was a recommendation to use digital technologies for drug-sensitive TB, but nothing about MDR-TB. So what we've done was to develop the decision analytic model to assess the cost of 3 patient-centered DOT approaches. So these were the video observed treatment, 99 dots, family observed DOT. And we chose these because these were the only ones we could get some costing data and some information on them being used as a treatment delivery strategies in TB. We've done the costing for Ethiopia, India, and Uganda, which were 3 of the 30 high TB burden countries, and also part of STREAM. And as source of costing, we use World Bank estimates of income per capita. We use local unit costs from STREAM and also local sources. And we looked at the 40-week injectable containing regimen. This was because that's the only data we had at the time when this study started. But also, if we want to extrapolate and think about the oral regimens now, we would only have, the overall cost would only decrease, because in this model, we assume that patients were going to the health facility to have their injectable treatment. And also very important, we couldn't find any kind of clinical trials that would assess or directly assess the effectiveness and the effects on the outcome of these treatment delivery strategies. So what we've done was to assume that the alternative regimens yields the same treatment outcomes as the standard of care. There were papers who were saying that these methods of delivering TB treatment can improve adherence, can improve outcomes. There are other papers who are saying that not always. So just to be on the kind of safe side, we assumed that it yields the same treatment outcomes. And here are the results. So from a societal perspective, the VOT, video observed therapy, 99 dots, and family observed therapy were the least expensive. So they were cost saving versus standard of care. However, when we're looking at the health system, the VOT was considered more expensive because when we've done the costing, we've also included the all the equipment needed to deliver the treatment. So we looked at the treatment penetration rates and internet coverage. So what we said in the VOT strategy, we said, well, we're going to buy smartphones for all TB patients, and we'll also pay for their internet. So when there was a low smartphone penetration rate, you'd have to buy more phones. So this is a system that's actually being used in the UK. And at the end of the treatment, their TB patients are returning the smartphones, and those are being used by other patients. So just as a conclusion, from a societal perspective, digital technologies and family-supported DOT are less costly compared to standard of care DOT, which requires patients to go to the health facility every day or every 2 days, if I remember correctly, in India. Provides savings for patients, reduction in time and cost of traveling to from treatment centers. It's also worth to note that the 99 dots and VOT require high startup costs, as I mentioned, because we had to buy, we assumed that we were to buy the smartphones. And on the left side, sorry, I forgot to mention at the beginning, the 99 dots basically means that when a patient is dispensing a pill, a phone number will appear, as in the picture. The patient would call that phone number that would be like automatically registered in a system where the health worker would have access, and the health worker would know how many times the patient called. And if the patient doesn't call, I don't know, say 2 days in a row, then the health worker calls the patient or asks the patient to come to the health facility or switches to a normal dot. So some key takeaways. I think in STREAM, we looked at the long-term follow-up because we follow patient up to week 76, and the treatment duration was 40 weeks or lower. However, we need longer term follow-up to understand post-TB health, post-TB costs and care needs. We also need to listen to the patients, so we need to use qualitative insights to uncover the real burden of indirect costs. And we've collected, as part of STREAM, we've collected some qualitative data that is not yet published. And I'm telling you, what the patients were saying and what the patients were experiencing is just unimaginable. And also, we need to implement social protection measures to reduce financial shocks and break the TB poverty cycles. And last but not least, of course, we've made significant progress with shorter or oral regimens. With the new drug, we had bedaquiline, but bedaquiline resistance is already emerging. So how are we preparing for what's next? I just wanted to thank you all. Thank you to the participants and collaborators without whom the STREAM study would not have been possible. Thank you.
Thank you everyone for attending. I hope you've found it as interesting as I have. And again, thank you to Frederick and the COMBINE team for supporting the webinar.
Absolutely. Thanks a lot to everybody.
Thanks so much for having us.
Thank you.
Thank you.